Good, good evening, everybody. Welcome to this discussion on the anatomy and physiology of the adrenal gland. Adrenal is an important gland, both surgically and even more so physiologically. Um, Many of them are not generally seen by general surgeons, but we have had opportunity to operate on a few adrenal masses, both by open surgery and at laparoscopy. It is important to know the intimate relations of the adrenal, and even more so, and sometimes it may look very dry and very boring. One has to understand the physiology of the gland, because the physiology going out of gear can put the organism in great trouble, can put humans in great trouble. In the fetal stage, it may lead to abnormalities of the sexual organs, and you may end up with indeterminate sex and things like that with a functioning adrenal tumor. In the adult, functional tumors can be quite challenging many times to diagnose. And there is a whole class of diseases called incidentallomas, and we as surgeons must be very familiar with it. All these disorders will be discussed in the next class, but for now, we stick to the fundamentals and learn about the anatomy and the physiology. Over to you, Pavan.
Thank you, sir. Sir, am I audible, sir?
Yes, you are. Slides are seen. Go ahead.
Yes. So, good evening, everyone. I am Dr. Pavan Kumar, second year DNB resident from Sagar Hospitals. Welcome to today's session on anatomy and physiology of adrenal gland. Starting with the embryology, adrenal gland is also known as suprarenal gland, and it is an endocrinal gland. Adrenal gland contains outer cortex and inner medulla. Outer cortex is developed from the mesodermal tissue near the developing gonads on the suprarenal ridges. In fetal cortex, actively produces steroid hormones during gestation and involutes after birth. Definite cortex is developed slowly after birth, and medulla is developed from the neural crus cells or neuroectoderm, which migrates the medial portion of the developing gland and encapsulated by the adrenal cortex. These are the changes in the size of the adrenal gland. At birth, the size of the adrenal gland is around 1/3 of the size of the kidney, and during adulthood, the adrenal gland is 1/30th size of the adult kidney. Adrenal glands is a pair of retroperitoneal organs, and it is related to the upper pole of the kidney. And these are contained in its own subcompartment within the Gerota's fascia. Adrenal gland contains outer cortex, which is spiculated and mustard yellow color, whereas adrenal medulla is central and it is brown yellow in color. Each adrenal gland is around 4 to 5 grams each, and it is around 4 to 6 centimeters in length and 2 to 3 centimeters in width. The right adrenal gland is around triangular in shape, and the left adrenal gland is crescentic in shape. Various relations of the adrenal glands. The right adrenal gland, the anterior surface of the adrenal gland, medially it is related to the inferior vena cava, and laterally it is related to the right lobe of the liver, including the Barre area of the liver. Whereas posteriorly it is related, superiorly it is related to right crus of the diaphragm, and inferiorly it is related to kidney. Medially it is bounded by right celiac ganglion and right inferior phrenic artery, and the hilum of the right adrenal gland is near the upper end. Whereas the relations of the left adrenal gland, for the anterior surface, superiorly it is related to the stomach, and inferiorly it is related to the pancreas and the splenic artery.
You're on the left gland. Yeah, go on.
Yes, sir. Posterior surface of the liver is medially it is related to the left crus of the diaphragm, and laterally it is related to the kidney. The medial border is bounded by left celiac ganglion, left inferior phrenic artery, and left gastric vessels. The hilum of the left adrenal gland is nearer to the lower end, and it is related to peritoneum of the omentum bursa, which separates it from the stomach.
So what is your thinking on the location of the hilum? You talked about the anterior surface. Go back one slide. Talked about the anterior surface. What is the importance of this? Surgical importance.
Sir, in case of right adrenal gland, while doing adrenal surgeries, we are more cautious in the medial side because there is inferior vena cava, major vessels.
Correct.
And
talked about the bare area of the liver.
Yes, sir.
So what does it mean?
So the area where there is no peritoneal covering to that liver, sir.
Is the bare area on the inferior surface or the posterior surface of the liver?
Posterior surface of the liver.
So when you say that it is related to posterior, to the bare area, what does it mean to you? The upper part of the right adrenal gland is actually behind the liver.
Liver, yes, sir.
So you have to superiorly displace the lower border of the right lobe of the liver to get at the superior part of the right adrenal gland.
Okay,
all right. Yes, similarly, the hilum that you talk about is near the upper end. So
yes,
it is tucked very closely to the liver, and that makes dissection difficult.
Yes.
Okay. And there's a third point about the adrenal vein. I'm sure you're going to talk about it later.
Yes.
But apart from the adrenal vein, surgeons must note that the right lobe, the right adrenal is behind the liver, and the hilum is very close and behind the liver as well many times. And so getting at it can be a lot more challenging on the right than on the left. Okay.
Okay, sir.
Go ahead.
Yes. So these are the relations of the adrenal gland as I explained in the previous slide, as shown here. The arterial supply of the adrenal glands is copious, and it is mainly supplied by three major vessels. These are superior adrenal artery and the middle adrenal artery and the inferior adrenal artery. Superior adrenal artery is a branch from the inferior phrenic artery, and middle adrenal artery is the branch from the aorta, whereas inferior adrenal artery is branch from the renal artery. The main adrenal arteries branches to form a subcapsular plexus.
Honestly, at surgery, it is difficult to identify these arteries individually.
Okay, sir.
Veins are easily identified, but looking at the superior, middle, and inferior arteries as named vessels is very unusual at actual surgery. That is something you must bear in mind. Yeah, go on.
Yes. Medullary veins coalesce to form adrenal vein, and single main vein is present on each side. Right adrenal vein, which is shorter in course, and it is directly opens into the inferior vena cava. Left adrenal vein is longer in course when compared to right adrenal vein, and it joined with the inferior phrenic vein and directly opens into the left renal vein. The left two images show normal adrenal anatomy, and right two images show variations in the venous system of the adrenal anatomy. So here, normally the right adrenal vein directly opens into the inferior vena cava. Here, there could be variations like one central vein with multiple accessories, or right adrenal vein directly opens into the right hepatic vein. Similarly, in the left adrenal veins, various adrenal anatomy, venous variants like the left adrenal vein, initially it opens into the left phrenic vein, then opens into the left renal vein. Sometimes it could be two adrenal veins or separate inferior phrenic veins will be present.
It is to be noted as a general rule that venous variations or variations in the venous system are a lot more common than variations in the arterial system.
Arterial system.
It is true of adrenal veins also. Go on.
Yes, sir. Adrenal veins may present with multiple anatomical variants which surgeons should be aware of while performing surgeries. As there could be a collaterals and axillary adrenal veins, caution must be taken during surgeries. Adrenal venous sampling is a gold standard diagnosing procedure in primary hyperaldosteronism, and it requires thorough knowledge of the adrenal vein anatomy to avoid iatrogenic injury. Adrenal vein acts as an important conduit in portosystemic stents. This is the vascular supply of the adrenal veins as shown in the image. The right adrenal vein drains into the para-aortic lymph nodes and the nodes near the right crest of the diaphragm, and the left adrenal vein drains to the nodes near the origin of the left renal artery and the para-aortic lymph nodes. Coming to the nerve supply of the adrenal gland, the adrenal cortex appears to have only vasomotor innervation. Most of the fibers reaching the gland from the splanchnic nerves and the lumbar sympathetic chain and the celiac plexus enter the medulla. These fibers are preganglionic and end on the medullary chromaffin cells. Sir, can I continue, sir?
Yes. Any questions or doubts from the audience? Okay, go on.
Yes, sir. So the image in the slide shows histology of the adrenal gland. So adrenal cortex contains three zones: zona glomerulosa, in which it contains cells in a spherical manner, and zona fasciculata. In these, cells are arranged in a straight columns separated by fibrous septa, and zona reticularis. In this, the cells are arranged in a irregular net-like fashion. In adrenal medulla, it contains special cells called as chromaffin cells. These are of two types, chromaffin A and chromaffin N cells. The chromaffin A secretes adrenaline and chromaffin N cell secretes noradrenaline. Adrenal cortex secretes steroid hormones, which helps in maintaining the mineral balance, energy balance, and the reproductive function. As I discussed in the earlier slides, so the adrenal cortex is divided into three regions: zona glomerulosa, zona fasciculata, and zona reticularis. The zona glomerulosa mainly secretes mineralocorticoids, like the principal hormone is aldosterone, whereas in zona fasciculata it secretes glucocorticoids like cortisol, and zona reticularis produces sex hormones. Adrenal medulla secretes catecholamine hormones like adrenaline, noradrenaline, and dopamine. This image shows the pathway of the adrenal steroid biosynthesis in the adrenal cortex. So all these hormones are synthesized from the cholesterol, where in the case of zona glomerulosa, the aldosterone is synthesized from the cholesterol through various steps, like it converted into pregnenolone, then progesterone, and 11-dehydroxycorticosterone and corticosterone. Similarly, in case of the zona reticularis, the sex steroid hormones are synthesized from the cholesterol through various steps, like pregnenolone is converted into 17-hydroxypregnenolone and finally converted into dihydroepiandrosterone. Similarly, in zona fasciculata cells, the cholesterol is converted into cortisol and corticosterone through various steps, like the pregnenolone is converted into 17-hydroxypregnenolone and 11-deoxycortisol, and similarly the pregnenolone converted into progesterone and finally to 11-dehydroxycortisone and corticosterone. So the deficiency of these enzymes like 17-hydroxy hydroxylase and 21-hydroxyhydroxylase and 17-20-lyase enzymes may lead to congenital adrenal hyperplasia.
So, Pavan, go back one. Do you remember the name of that basic ring? It is stuck in my head from my biochemistry days. So anybody, if do you know what that thing called, that ring is called, as you can see, the structures are very closely related. Okay, that ring, that basic ring that you have has various side chains which make it, they're closely related, but they make them different hormones with different functions.
Sir, cyclopentanate phenanthrene ring.
You're nearly there. Anybody else? Anybody else?
No, sir.
Cyclopentano perhydrophenanthrene.
Okay, sir.
It is not important to know this, but somehow that is stuck in my head, and that's why I asked you that question. Examiners and teachers have this prerogative, they only ask what they know. They may not know a lot more things. Anyway, so please note that it is important that the basic structure is the same, and various enzymes add and subtract side chains on the basic basic chain, basic structure, chemical structure, and you get various kinds of hormones. So you can see how easily things can go out of gear, and it is such a complex but closely related biochemical pathway. Okay, so things can go out of gear, as we will learn more in the next class. Go on.
Yes. Coming to zona glomerulosa, which produces mineralocorticoids, the principal hormone produced from the mineralocorticoids is aldosterone. It's mainly secretion is mainly under the control of renin-angiotensin system. The main action is to increase distal tubular reabsorption of the sodium and excretion of potassium. So, renin-angiotensin aldosterone system, during hypotension states, the renin hormone enzyme is produced by the kidney, which acts on the angiotensinogen produced by the liver, which converts the angiotensinogen to angiotensin 1. The angiotensin 1 is converted into angiotensin 2 with the help of an enzyme, angiotensin converting enzyme, which is produced in the liver. The angiotensin 2 acts on the tubular cells and helps in the resorption of sodium and water and excretion of potassium. And angiotensin 2 is a potent vasoconstrictor and helps in increasing the blood pressure, and it acts on the posterior lobe of the pituitary gland and secretes the ADH hormone and helps in the resorption of water. Angiotensin converting enzyme inhibitors helps in maintaining hypertension, like captopril, enalapril, and ramipril. And similarly, angiotensin 2 receptor antagonists are also helps in used in hypertensive conditions like losartan and irbesartan and candicertan. Direct renin inhibitors like Eliskiren and ramiskiren are used for the hypertension, and vaccine against angiotensin 2 for the treatment of hypertension like CYT006 antigen QB can be used. Zona reticulata, which is present between the zona glomerulosa and reticularis, and it produces glucocorticoids like cortisol, corticosterone, and cortical secretion is principally regulated by corticotropin hormone. From the hypothalamus during stressful conditions like either physical stress or emotional stress, the hypothalamus is stimulated and it produces corticotropin releasing hormone, which acts on the anterior pituitary and which secretes adrenocorticotropic hormone, and adrenocorticotropic hormone acts on the adrenal cortex and produces the cortica and cortisols, and acts on the target organs and produce the required effects. The cortisols and ACTH are produced in a pulsatile manner with a characteristic circadian rhythm. It is seen high in the early mornings and low in the evening, what we call it as diurnal rhythm.
Pavan,
Yes, sir.
let's go back. Is cortisol a anabolic hormone or a catabolic hormone?
Sir,
What are the
cortisol is catabolic, sir.
Yeah, why is it called catabolic? It's a very fundamental question.
Sir, because it acts on the compounds and like it acts over the fats and produces fatty acids and glycerols and proteins.
It breaks
And
down all the things that actually constitute the body in terms of fat, protein, and carbohydrate. It breaks it down
yes, sir.
to produce fuel for a stressed phenomenon. That's why it's catabolic. You talked about diurnal rhythm. When is your
Yes.
cortisol at the lowest ebb? What time of the day?
During sleep, sir.
What time of the day? You sleep a lot, right? 8 hours,
No, sir.
7 hours, 6 hours. So what time of the day? Lowest ebb. Hari?
Sir, midnight, sir. 12, I'm not sure.
Right.
I know it's midnight.
Kavya, you want to have a go? Are you there? Kavya, you want to have a go? We'll ask our youngest man who has come through a DNB qualifying exam. Vinod, when is the cortisol at the lowest ebb?
3 in the morning, sir.
Yeah, you're right. 4 a.m. About that. Okay. 3 to 4 a.m. is the lowest ebb. All right. Go on.
So various metabolic effects of cortisols or the carbohydrates. As sir, as we discussed that it is a catabolic hormone. Cortisol stimulates gluconeogenesis and increases the leads to increase in the glycogen storage in the liver. And cortisol has a property of anti-insulin property, so it decreases the rate of.
I think you got it wrong there. It doesn't increase the glycogen storage. It breaks down the glycogen in the liver through gluconeogenesis. Okay.
Okay, sir.
Yeah. Glycogen storage cannot occur, even though I know some book might have told you this, but it actually leads to breakdown of glycogen stores that is already there. Please double check this particular point.
Okay, sir.
Okay. See,
Yes.
this may happen in the non-stressed state. Okay, when it causes gluconeogenesis either from fat or protein, when it's a non-stressed state, it may that increased glucose is stored as glycogen in the liver. That is understandable. But
Yes,
we
sir.
were talking about a stressed state when cortisol is stimulated. So it starts gluconeogenesis and it also causes glycogenolysis. Gluconeogenesis is from what? Where does glucose come from? Let me not say everything.
Sir, from the non-carbohydrate stores like from alanine or
From amino acids and fatty
amino
acids.
acids.
Yeah, that is
Yes.
gluconeogenesis.
Yes, sir.
Also causes glycogenolysis. Okay, which
sir.
means in the non-stressed state, I agree with the second line. It can increase glycogen storage, but in the stressed state that we are talking about now, it actually stimulates the mobilization of glycogen. Go on.
Yes. So cortisol is anti-insulinic. So cortisol decreases the rate of glucose utilization by the cells as a response to insulin inhibition. Cortisol is a catabolic hormone, so it decreases the protein synthesis in the body cells except those of the liver. Increase the catabolism of protein in many extra hepatic tissues like muscle and the lymphoid tissue. If in the presence of excess cortisol, muscle becomes weak and immunity function of the lymphoid tissue will decrease. Cortisol is lipolytic and it increases the free fatty acids and glycerol, and it increases oxidation of the fatty acids in the liver cell for the energy generation. Cortisol increases the production of various blood cells like neutrophils, monocytes, platelets, and RBC, and it decreases the number of lymphocytes and eosinophils. Glucocorticoids is necessary for the maintenance of normal blood pressure through various mechanisms like it causes permissive action and enhances the response of vascular muscle to catecholamines. It inhibits the synthesis of prostaglandins, leading to vasodilation, and it reduces the permeability of the capillaries, which maintains the blood volume. It causes sodium absorption and potassium excretion by distal tubules and collecting ducts in the kidney. So it increases the rate of renal blood flow and the glomerular filtration rate. Glucocorticoids helps to treat in water intoxication in patients with adrenal insufficiency. Stress causes increase in the ACTH secretion and consequent cortisol secretion, and various other effects like on GIT, cortisol causes increase in the gastric acid secretion, which leads to production of HCl and pepsin, and it also helps to promote the synthesis of fetal surfactant, and it has pharmacological uses like anti-inflammatory, anti-allergic, and anti-shock effects.
Pavan,
Yes,
go
sir.
back.
Yes, sir.
When we talk about these things, we can make it interesting by correlating these actions with certain specific clinical conditions that you need to be aware of. Okay.
Yes, sir.
In that sense, in the other effect, you have mentioned three things.
Yes, sir.
Give me one example of a clinical result or clinical effect of each of these three things that you have mentioned there.
This other effects, sir.
Yeah.
Sir, promote synthesis of fetal surfactant means if the gestation age of the baby is less than 28, and if there is a so premature delivery, we can give cortisol, sir, so that it helps in surfactant production, sir, and lung maturity.
Correct. Fetal surfactant, is it applicable only to the fetus, or surfactant has a role to play in adults also?
Actually, the main role of surfactant is to reduce the surface tension and proper expansion.
So where do you think then it would apply in an adult? Not necessarily, what you said about a newborn is understood, but what about in the adult?
In case of ARDS?
Yes, correct. It is protective against ARDS. What about the first point?
Sir, in case of stressful conditions, gastric output increases, so HCl production leads to
just one line, one word.
Peptic ulcers, sir.
Stress ulcers.
Stress ulcers.
That's all I need. Okay. What about the last one?
Sir, anti-inflammatory by inhibiting the leukocyte migration to the site of inflammation, sir. And anti-allergic is by inhibiting leukotrienes produced from the arachnoid.
I understand. What is I'm asking about clinical effects, Pavan?
Anti-inflammatory.
Any inflammatory condition, collagen disease.
Yes, sir.
All right. Any number of surgical conditions which are inflammatory. You can use steroid to reduce the inflammation, yes, including anaphylactic reactions. Okay. And there is a lot of question about anti-shock effect in patients with septic shock. There are specific indications. I won't go into it, but you understand that the idea of understanding the effects of these compounds is not to just mug it up, but see how it helps you in clinical, in treatment, actual treatment of patients. In that way, you'll find it more interesting to discuss and more easy to remember. Go on.
Yes. Sir, these are the therapeutic
summary.
effect.
You can skip this,
yes,
slide. Yeah.
Yes. Coming to zona reticularis, it is the innermost cortical layer. It produces androgens, which are the precursors for estrogen, testosterone. And zona reticularis produces sex steroids like dehydroepiandrosterone, dehydroepiandrosterone sulfate, and androstenedione. So as I discussed in the earlier slides, that the cholesterol, from the cholesterol, the steroid hormones are synthesized, that is androstenedione and dihydroepiandrosterone. In normal conditions, adrenal androgens have insignificant physiological effects because of low secretion both in males and females. In congenital hyperplasia of the adrenal cortex or tumor of the zona reticularis, excess amount of androgens is secreted. In males, because of the normal sexual hormones like testosterone, they won't have that much effects. But in females, adrenal androgens is required. So in females, if there is excess hormone production, that leads to uh, helps in axillary hair growth, pubic hair growth, and libido.
No, that is not excess. It is the
No,
normal
sir.
amount. If it's in
That means
excess,
normal,
what
sir.
happens? If it is in excess, what happens?
Yes, sir. Excess
What is
leads
that condition called?
sir, adrenogenital syndrome, sir.
Virilization.
Virilization, yes, sir.
That's the name for it. Go on.
Yes. Adrenogenital syndrome is occurs due to an adrenocortical tumor that secretes excessive adrenal androgens. Testosterone is responsible for this activity in this syndrome. The predominant feature in this syndrome is virilization. This condition is severely seen in females, causing pseudohermaphroditism. The clinical features like deep voice, growth of the beard, masculine distribution of the body hair, baldness, acne, and clitoromegaly. In prepubertal boys, there is a rapid development of the male sexual organs, leads to precocious puberty.
Okay, we'll stop here, take a break. Any questions, doubts, or comments, please? Okay, nothing. Go on.
Adrenal medulla constitute about 10% of the adrenal mass, and it secretes catecholamines like epinephrine, norepinephrine, and dopamine. The other sites of synthesis of these catecholamines like regions of the central nervous system, chromaffin cells of the adrenal medulla, and postganglionic adrenergic neurons. And it is stimulated by the sympathetic activation and also cortisol from the adrenal cortex.
As you mentioned earlier, basically
Yes.
the adrenal medulla is the postganglionic neuron
Yes, sir.
of the sympathetic system. Yeah, go on.
Yes, sir. During stress conditions, there is increased production of the catecholamines and the glucocorticoids. During stressful conditions like any physical activity or low blood glucose levels, so the hypothalamus is stimulated and it produces action potential and sympathetic from the ANS system, and it stimulates the adrenal medulla, and it increases the production of epinephrine and norepinephrine secretion. So it acts on the target tissues and producing the following effects like increase in the release of the glucose from the liver, increase in the release of the fatty acids from the fat stores, and increase in the heart rate, and a decreased function of the visceral organs, increased blood sugar, blood pressure levels. The catecholamines are produced from the amino acids like phenylalanine through various steps, like the phenylalanine is converted into tyrosine. From tyrosine, it is converted into dopa, and from dopa, it is converted into dopamine and norepinephrine and epinephrine. So the catabolism of this catecholamines, like dopamine will produces homovanillic acid, and norepinephrine will produce normetanephrine and vinyl mandelic acid, and epinephrine produce metanephrine and vinyl mandelic acid. The significance of this enzymatic degradation is the enzymatic degradation of this catecholamines through catecholamine O methyl transferase and monoamine oxidase. Monoamine oxidase inhibitors are used as antidepressant drugs to prevent the degradation of the catecholamines in the CNS, and leads to elevated concentration of the catecholamines in the synaptic clubs, leads to improving the depressive symptoms. The end stage metabolites like vinylene mandelic acid is used having a diagnostic value in case of elevated urinary excretions in the patients with pheochromocytoma and neuroblastoma. The functions like sympathetic activation, and it has fight or flight reaction, that is, and various other mechanisms like catecholamines binds to various adrenergic receptors located on the different organs, and it acts through the G protein coupled receptors and trigger the required response. These are the various peripheral adrenergic receptors, that is alpha and beta receptors. Through G protein coupling signal transduction, it acts on the different organs like the skin and GA system. It leads to increase in the smooth muscle contraction, leads to vasoconstriction, and in GA tract it increases into the constriction of the sphincters.
Hari, it's difficult to remember this. It's good that you have shown this table. I think every one of us must keep referring to this. At this stage, suffice it to know that there are different adrenergic receptors and they have different functions in different tissues.
Yes, sir.
Okay, all right, go on.
Various extra adrenal sites of the adrenal hormones in some conditions like small cell lung carcinoma and carcinoid syndrome, and pheochromocytomas, medullary thyroid carcinomas, pancreatic carcinoma, and other non-neuroendocrine tumors. In this condition, there is a excessive production of the ACTH, and the ACTH like substances leads to Cushing syndrome like features will be. Thank you.
Yeah. All right. It is important to know that when you have syndromes which suggest that you have that it is coming from the adrenal, and if it is not from the adrenal on your investigation, you must look for other sites, and that is why I asked Pavan to put up that list. All right. If you can stop sharing your screen.
Yes.
I would like to invite people to add or subtract things and give your comments, both about the subject and the presentation. Kavya, can we start with you?
Sir, good evening, sir. Overall, it was a good presentation.
Get your video going. It's nice to see each of us. Yeah, if you have the bandwidth.
Yeah, 1 second.
Yeah, go on.
Sir, overall, it's a good presentation, sir. It was concise and extensive. Nothing much to add, sir.
All right. What did you think of the presentation? It's a dry topic and it's difficult to make it interesting. I think Pavan did a reasonably good job. Yeah.
It was concise and it's good.
Is there anything that we did not cover?
None that I can think of currently.
All right. Yeah. Nishant?
Sir, it was a good presentation, sir. Nothing much.
Yeah.
Probably if it was included with some operative video,
yeah,
or case-based scenario or something. Probably.
Actually, I actually thought of doing it. Showing, I have clips of laparoscopic adrenal that I have done. I thought of it, but then felt too lazy to edit and give it to him. Basically, Abdul.
Sir, that's what, sir. I think by splitting the class into two,
yeah,
I made it more boring, I think.
No. I think you're all right. One of the things I seriously considered was to include investigation in the basics. But then I asked Pavan, he said, no, we'll do it in the next class. And I agreed with that. So I think it'll be more, remember this class when we meet next, so that particularly in the assessment, the hormonal assessments and the tests that we do to know about hyperfunctioning of the adrenal, then we'll learn a lot more about it. And I'll also try and include an endocrinologist to help us with the adrenal tests. Okay, we'll remember, Abdul, remember that we'll involve an endocrinologist for the next class. It's not just necessarily only operative treatment. We must also know about the physiology, and by that time I'll get over my laziness and edit my videos and give it to you, the adrenal.
Yes, sir. Sure.
Yeah. Okay, others, hurry.
Sir, very nice class, sir. By splitting two, I was able to concentrate.
A very loyal friend to Pavan. Okay, Vinod.
I'm new to these things, sir. I'm very interesting to see these things.
All right, so you will have a lot more of it, and by the time you're a few weeks old, you'll probably had too much of it. Anyway, all right, Indraja.
Sir, this is a very nice presentation, sir. Pavan
Okay.
did very well, and
Right.
he covered both anatomy and physiology very well, sir.
All right.
Sir, I want to know, like, when you are doing adrenalectomies,
Mm-hmm.
what difficulties you have faced?
We'll talk about it in the next class.
Okay, okay,
We'll
sir.
show it to you with an actual operation, video of an operation. We'll do it next time.
Okay, sir. Okay, sir.
All
Thank
right.
you, sir.
Okay.
Thank
All right. How is what's Janani doing? She's
Yes, sir.
off
She's
work
with.
or
I try to ask her to attend classes when possible, sir.
she may be
The day
busy
case-
with a baby. Yeah.
Yes, sir. That day she tried to attend the class of the presentation, case presentation. That day also she couldn't attend.
All right.
in between.
Okay. Is she back at work or is she finished?
No,
What's
no, sir.
happening? Yeah.
No, sir. She will. I don't know when she's coming, but she's not
All
yet.
right.
Sir.
All
Maybe
right.
next week.
Okay. All right. Good. Thank you. And
Thank you, sir.
good night. And we'll remember next time we will have a little more interesting, both in terms of investigations with an endocrinologist and with some operative videos. Okay.
Sure, sir.
All right.
Sure.
Bye
Thank
bye.
you.
Good night.
Thank
Good night.
Good night, sir.
Good night, sir. Bye.
Good night.